Welcome to the recording of the webinar, Reflection on Adult and Elderly Health, Early Detection, Prevention, and Vaccination. The webinar is hosted by Dr. Ferdinando Petrazzuoli. The presenters are Professor Shlomo Vinker, Professor Mehmet Ungan and Professor Thomas Frese. This webinar was recorded on the 14th of December 2023.
Dear colleagues, ladies and gentlemen, good evening and welcome to this Wonka Europe webinar on reflection on adult and elderly health. As we age, our health needs change, and it becomes increasingly important to focus on evidence-based medicine procedures for early detection, prevention, and vaccination to ensure healthy aging. This reflection explores the significance of these aspects in promoting health and longevity. This evening, we have the privilege to have with us three distinguished speakers. All of them are Wonka Europe President. We have the current Wonka Europe President, Professor Shlomo Vinker, the former Wonka Europe President, Professor Mehmet Ungan, and the future Wonka Europe President, Professor Thomas Frese. Let's start with Professor Shlomo Vinker.
Good evening, everybody, and I will share my screen and my presentation, and we will start. Okay, so we can start. So again, good evening to everybody. And my part today will be to talk about early detection. So as I was already presented, my name is Professor Vinker. I am Wonka Europe current president. And and these are my affiliations. I'm the Chief Medical Officer of Leumit Health Services in Israel. This is one of the healthcare organizations in Israel. We are serving more than 700,000 members all around the country. I'm the Vice Dean at the Medical School at Tel Aviv University, and also the Treasurer, the past Chairman of the Israeli Association of Family Physicians. Okay, so the European population is getting older. When I was a medical student many years ago, the distribution of population, the population pyramid was presented as a Christmas tree. And now we are near Christmas, so everybody knows what I'm talking about when I'm saying Christmas tree. This was the classical demographics that was presented many years ago. But if we are looking today about the population in Europe, then we see that we already lost the figure of the Christmas tree, and you can imagine like it seems more like a fat old lady or something like this, which means that there are less younger and much older, and a lot of very old people among our residents and also among our patients. And as you can see, the number of the total population of Europe is becoming quite stable in the last few years. The birth rate is going down, which means again, the population is stable, but the average age is getting older and older. And what does it mean to us as family doctors that our patients are getting older? The workload is increasing because for each patient, we have a greater chance to have a patient with multimorbidity, with polypharmacy, frailty. And on the other hand, the time per patient is reducing because there is shortage of doctors, there is increasing bureaucratic tasks, and of course, patients nowadays are more demanding. We call it consumerisms. The patients are consumers, and they are not our patients, they are our consumers, and they have their own demands. So at the end, when this balance is moving between increasing workload and reduced time per patient, the first thing that is interrupted is preventive medicine. So we are doing less preventive medicine and less early detection. And in such situation, when we are doing less, we have to focus on what is evidence-based. And usually when I'm talking about prevention, I like to cite the US Preventive Services Task Force, although it's not from Europe, it's from the States, but they are very systematic in their recommendations. And as you can see, this is the scale. A and B actually is high-grade recommendations to do a service or a procedure. C is something that is equivocal. D is against, we are against this procedure. And I is something that we don't have enough information. So let's go and see what are the recommendations for early detection of cancer. So the easiest way is to start with D. They don't recommend to do any ovarian cancer screening, thyroid cancer screening, and pancreatic cancer screening, which is quite clear. They say that there is not enough information, not enough scientific background about skin cancer screening, oral cancer screening, and bladder cancer screening. So we can omit all those 6 and go, and let's go to the main recommendation, positive recommendations. So grade A is about pap smear for early detection of cervical cancer, but this is until the age of 65. And when we are talking about the elderly, above 65, the recommendation is turned to D. So there is no need for cervical cancer early detection in the elderly. Of course, what I'm talking is about the general population. If there is a specific risk, all the recommendations are different. We are talking about screening of the healthy population. And what is in the category B? Category B is about lung cancer screening in patients that are smokers, and also mammography for the age of 50 to 74. And we are moving forward to C, and this recommendation is about PSA. And as you can see, until the age of 70 is C, which is a weak recommendation, but above 70, it is D. So they are recommending against prostate cancer screening after the age of 70. And what about colorectal cancer screening? So the target age of 50 to 75, it's A. There are now a lot of debate about starting it a little bit earlier, which means at the age of 45, but between 45 and 49, the recommendation is B. And after 76, it's turned to C. It's still positive, but weak. So we can see that the recommendation is also depending heavily on the age of the patient. To make this story of age clearer, I would like to share with you a study that I did several years ago in the previous healthcare organization where I served. And these are my colleagues. And we tried to see the concept of targeted screening, not according to age groups, but according to life expectancy. It means that you see people now are getting older and older, so the recommendations should be corrected to the life expectancy. And in this study, we used what we call, I'll show you later on, a Schoenberg index, and she is one of the members of this, of the authors of this manuscript, and we surveyed for breast cancer, prostate cancer, and colon cancer. This is at the end, the target population. We calculated for each member of our HMO the life expectancy according to Schoenberg index. And we said that this index, we can calculate it because we have the database. And we decided that if an adult have more than 50% risk of mortality within 10 years, based on this calculated score, then we decided that those patients have less than 10 years life expectancy. And what we did find in this huge cohort of hundreds of thousands is, and it starts at 65 years because the Schoenberg index can be calculated and validated only above the age of 65. So we can see here that in usual clinic, without any instructions, family doctors and also the patients themselves feel that when you are in the same age group, but with lower life expectancy, you are doing less early detection procedures. You see, PSA is something controversial, so put it aside. But as you can see, for example, mammography, at the age of 65 to 69. If you have lower life expectancy, then you do less screening. And the same in each group and in each recommendation for early prevention. So as you see, it's interesting that we have to move from talking about early detection according to age groups and to move it to the individual patient. And to summarize my lecture, at the end, it will be AI or algorithmic, and not one size fits all, which means the algorithm will be able to detect and to calculate or the approximate longevity expected to the patient, and the recommendations will be tailor-made for the specific patient. So with this optimistic view of the future, I will stop sharing my screen. Thank you.
Thank you very much. Thank you very much, Professor Shlomo Vinker. And now the floor is for Professor Mehmet Ungan.
Thank you, my chair, Ferdinando, and my good friend, and thank you for all, including me also, together with my colleagues, the next president, president-elect, and current president Shlomo Vinker, whom are really very good colleagues of mine also. Thank you very much. I will need to share my screen as I see. Hopefully you see all of them. And my task is just about to talk about the prevention. It's a huge issue, you know, such as we go for the, you know, if you just pay attention to Shlomo's slides, the United States Prevention Task Force has a kind of, you know, huge work. I will not go over that, but I will try to be focused on Europe for sure, and about the lifestyle modification programs, which are really proven to be effective. Risks, we are talking about the risks, and they require lifestyle modifications, and some of them are modifiable, some of them are not, non-modifiable. So when we just check the non-communicable diseases, we see that 77%, almost 80% of the disease burden, and 86% of the deaths in the region, our region, are the cardiovascular diseases, cancers, chronic respiratory diseases, diabetes, mental disorders, and most of them are really preventable when we check them. And when you just check as a GP, practicing GP, what are the prophylactic programs in the web search, you can see many items there, but some of them are evidence-based, some of them are not evidence-based for us in primary care, to be honest. You know, I mean, just every small details are uploaded to the primary care, but we have to be very careful on that. So when we look at the non-communicable diseases linked by common behavioral risks factors, if we go with the risk factors, it's so simple. Many of us know it: tobacco use, alcohol use, healthy eating, physical activity, and especially the body mass index is, you know, added to those four above, and just to be sure that we are taking care of the measures for the behavioral risk factors. And I think the primary care is the best one who will support and prevent them. Let's go and remember together to remind our patients most striking words. One of the most striking words in my practice is, I think after 40, if you stop smoking, 10 years of life could be gained, or at least you can save 10 years of life. This is a kind of very attractive wording for our patients. And just don't forget, the Europe is our region, and our region is on all the Wonka regions all the world, or WHO regions all the world. If you compare, I think tobacco smoking is the worst problem in our, continent. So when we go with the alcohol use, I think you can just say that 4 to 5 drinks a day lose 4 to 5 years of life. This is also a very effective sentence, and it is proven. So there is no safe level of exposure. This is according to the WHO, that we have to keep in our minds. When we go for the physical activity, just remember that 45%, nearly half of the Europeans, currently never exercise or partake in any physical activity. And what is the reason for that? They say that lack of time and lack of motivation are the first two reasons why they are not having a physical activity. And just to be honest, since 2017, nothing changed. This is an interesting value. And this is very important, that unhealthy eating, you can see on the right upper side here, UK, Belgium, and Switzerland. You know, this is a surprise for me when I'm checking. The junk food is terribly high level in those countries, which makes them under real risk. So when we look at my country here, Turkey, it should be having a lot of fruits and everything, but when you see it, you know, we have still not enough consuming of the healthy foods, let's say. And you can see where is your country here also. So when we go for those approaches, how to deal with them, we have to keep in our minds that the people in Europe have more than one risk factors. One, you know, they are usually having 2 risk factors or 3 risk factors. So I think the exposure to behavioral risk factors can cluster among some same individuals. And the result may be tending to multiplicative rather than additive. This is an important issue. And another important issue is, I think if we want to solve those problems, we have to be sequential rather than all at once. This is an important approach also, what it is proven. Why primary health care then? This is important to know, that primary health care delivers universal health coverage. That makes, you know, all the people access to the health care. And it has a vital role. And also we can see continuity, interaction with intersectoral and interdisciplinary agencies, coverage, resources, and evidences. They are all important for primary health care. And what is else? The quaternary prevention, which is very much mentioned in our EuroPrev group with our colleagues, Carlos and Broderson. This is important to think about it also, because this is kind of thing in our minds that we are agree or not, but this is something that we have to be thinking on also. How to measure the success of an intervention? By its reach, how many people we are reaching, by its effectiveness, by its cost. Those are the 3 major things which are showing us the effectiveness of those programs. And the key integration measurement and advice is a patient-centered conversation with a primary healthcare provider. This is very important. And you can see the star, patient-centeredness, non-communicable diseases, prevention, primary health care. It's in the middle of all of those measures, actually. And you can see that the WHO was prioritizing it. And you can see that Shlomo and me have been in the development of this brief project, which is ending with a manual of the non-communicable diseases and how to organize the brief interventions in country base. If you are interested in, you can go and see it in the WHO Europe webpage, which is online. So when we go with what kind of prophylactic programs are being considered, face-to-face, telemedicine, and digital-based programs. So which is effective? Digital programs seem to work best, but when facilitated by contact with a primary healthcare provider. So this is an important point also, I think. So when we go to effectiveness and cost effectiveness of prophylactic programs for tobacco use, it is evidence-based. United States Preventive Task Force is an important evidence, and they are putting the evidence on it. When we go with the alcohol programs, cost effectiveness, clinical importance, and digitally effectiveness are correct, and digital and provider together is the best in those programs. So when we go with the cost effectiveness of prophylactic programs of physical inactivity, cost effective or even cost saving, they are, which is very important for us. And increasing the level of physical activity in primary healthcare setting is the most effective one, according to the meta-analysis. This is an important message for us also. And when we go to unhealthy eating, there are three things. One of them is diabetes mellitus type 2, obesity, and cardiovascular risk factors found to be cost effective. The rest are not. This is important to know it. And when we go with the dietary advice, again, primary healthcare setting is found to be the cost effective, and a very brief 30-second advice to show the place where your patient will go, or to advise very briefly is the greater weight loss effect on your patients. This is very important also to know, and to force yourself to talk very little even. And when we go with the telemedicine approach, I think this is important to, and this is evidence-based, and probably Ferdinando will be also making a comment, because I think the rural areas, not only the rural areas, but those metropolitan cities, I think those approaches are very useful, as I see. Thank you for listening to me, and this is a very nice view to prevent your souls. And if you see that this is the wonderful view from the Bosphorus, Istanbul, and thank you very much. See you.
Okay, thank you very much, Professor Ungan, for your nice presentation. Actually, I think that most of us are a bit worried in hearing that, unfortunately, alcohol is dangerous. There is not a real threshold. So we have to abandon our drink. Okay, I think mental health is also important. So maybe a moderate drink will save our mental health condition. Okay, may I remind the attendees that at the end of the last presentation, we have a time to ask questions to our speakers. So the last presentation now is from Professor Thomas Frese. Thomas, the stage is yours.
Thank you. Good evening, my dear colleagues. I'm happy to talk here, moderated by Ferdinando, together with Mehmet and together with Shlomo. And I will talk about the vaccination for elderly. With the first slide, I present the vaccination scheme, an English version released by the German Robert Koch Institute, based on the recommendations of the German Vaccination Commission. And on the right side, since we are talking about elderly this evening, you see the recommendations for those people 60 years and older, regarding tetanus and diphtheria, regarding whooping cough, regarding pneumococcal vaccination, and regarding herpes zoster, influenza, and COVID. And what I will do with the next slides is go through it one by one and raise some aspects and mention some points which have changed. I think it's self-understanding that for tetanus and diphtheria, vaccination should be repeated approximately every 10 years in order to reduce the burden of disease and complications, including deaths. Target group is in principle every adult, especially the elderly should not be neglected. There is one point which I would really emphasize. It is issues coming regarding certain vulnerable groups like refugees and migrants. Currently in Germany, we see migrants coming without the basic immunization, without the basic vaccination. So it's not just to booster in that groups. And we even see among these non-vaccinated, we even see cases of diphtheria. So diphtheria of the skin or diphtheria of the throat. I'm sure most of it, including me, have never seen this before. And I was really surprised when I heard some weeks ago about the quite common presentations of diphtheria and of the skin amongst refugees. So this should be considered, and especially diphtheria of the throat is a reason to vaccinate in order to avoid complications. Whooping cough and pertussis, okay, it's one injection in order to renew and complete the protection for the elderly. It is indeed a differential diagnosis of persisting or chronic cough in the elderly, especially in nursing homes or similar conditions. And I was quite surprised when I searched the actual literature for the vaccinations just for the last few months. I was quite surprised about a study from England saying that whooping cough is causing a lot of healthcare expenditures. Mostly of it is indirect healthcare expenditures, and from the direct healthcare expenditures, the caregiving and general practitioners and primary care nurses setting are largely contributing to the costs. I was not aware that this is the case indeed. Regarding pneumococci, there's the point that some recommendations change, especially in Central European countries. For those over 60 years, one injection is recommended. And currently, to say for Germany, for Belgium, for our Central European countries, the 20-valent pneumococcal vaccine is highly recommended. Please do not forget that there may be special groups which have to receive pneumococcal vaccination earlier. I'm not talking about children's, young children especially, but I'm talking about patients after splenectomy. There are some news. I linked the publications. There's currently a 24-valent immunization, which is checked and has been shown to be as safe as the other ones. And the pneumococcal vaccine, which is 20 and 23-valent, can be assumed to be superior to the 13-valent one. As I said, the 20-valent vaccine is recommended, for example, in Belgium and Germany. It is also assumed to be cost effective, but, and that was a surprising finding when searching the literature, the evidence that the vaccination avoids hospitalizations and deaths is, especially for the subgroups of diabetic patients, quite scarce. There's still more evidence needed on that issue. Regarding herpes zoster, there are 2 injections which should be given with timely distance from 8 up to 24 weeks. The main aim is to reduce post-zoster neuralgia and pain. The target group usually is those older than 60 years, but it should not be forgotten that it's also those, older than 50 years with comorbidities already. Usually I see in the practices that people just think, colleagues just think about those 60 years and older, but the younger ones with chronic conditions are quite neglected regarding these vaccinations. It's clearly shown that, especially in patients older than 70 years, there is a reduction of pain and duration and also pain intensity and thereby burden of disease. It is shown that this vaccination also works in immunosuppressed patients, and it should not be forgotten that herpes zoster has a quite high burden of disease, but rather low costs. But the burden of disease is important for our patients, comparing influenza, herpes zoster, and pneumococcal infections. What is not fully clear regarding the herpes zoster vaccination is the benefit after zoster already broke out, and then to vaccinate after infection. Commonly, it is said that it should be 6 to 12 months. Some experts say it could even be that it's enough to vaccinate earliest 3 years after it. And there are still numbers lacking regard to cost efficiency, especially when I searched about it. I did not find numbers. This could also be a question for further research. Regarding influenza, it's clear it's 1 injection per year in order to reduce complications and severe courses. Target group is usually those older than 60 years, but also younger patients, of course, with chronic conditions. And please do not forget, it's a seasonal disease. So you may also think about when your patients are traveling from northern to southern hemisphere during the summer in the northern hemisphere. Made sense that they are vaccinated when going into the south. The high dose vaccines, which are used in some countries and depending of the concrete preparation used for those older than 60s or older than 65, are working better than the standard vaccines. They are from the same safety with the same rate of adverse events as the normal dosed vaccines. And very important, the practical hand, influenza vaccination may be co-administrated with the COVID vaccine. I think the highest problem we have this year with the influenza vaccination is that the uptake is very small compared to the years before COVID. And we also see during this year that the uptake of COVID-19 vaccinations is quite low. And I can tell from the German healthcare setting that we are right now dealing with COVID patients which are even hospitalized. We have some struggle with COVID patients in inpatient settings. So it should not be forgotten that COVID vaccination should be boosted at least or maximum 12 months after the last contact to the antigen in order to reduce complications and severe causes. Target group is also those older than 60 years. And do not forget to co-administer it with the influenza vaccine. It's safe. Patients will tolerate to get these 2 vaccinations at one time point, and it helps you really in the practice. So, and with that point from my hometown and from a home visit I did 2 days ago, I will end my presentation, and I thank you for the attention, and we are ready for your questions.
Okay, thank you very much, Professor Frese, for your very interesting presentation. So before the attendees, the participants ask questions, they can ask questions in the chat or in the Q&A tool. Let me ask or make some consideration myself. First of all, I was impressed by Professor Vinker's presentation when he stated that, unfortunately, although prevention is one of the core competence of primary care, it is the one which is affected most when you have other tasks to do, mainly bureaucratic tasks, etc., etc. And so this is a pity, because as we said, as primary care doctor, it's in our hand, the primary prevention of the disease. As a second consideration about the vaccine. I think that the vaccination, the key to success to vaccination is that, first of all, the vaccination should be completely free of charge. This is the key to success, because unfortunately, especially when we talk about rural settings, about equity in healthcare, being free of charge is an essential requirement. Third consideration is that many diseases have changed their epidemiological pattern. I'm a senior doctor. I've been working 8 years, and I remember that disease like herpes zoster, for example, had a completely different presentation in the past. So the epidemiological pattern has changed, and many diseases are much more aggressive than in the past. And also some diseases like pertussis, diphtheria, tetanus are not completely defeated. They are not something that we have won in the past. And we have to keep an eye on them and do the necessary vaccination. I don't know, I can't see any questions in the chat, so I will let each of you to make some further consideration on these aspects. First, Professor Vinker, you want to add more to your slides or to my consideration?
I can say in general about prevention, early detection, and vaccination, and that, as you said, this is one of the essence of our profession as family doctors. People can argue that you can remove those tasks to other healthcare professionals in the team, to a nurse, to healthcare, to health promoter, or even a secretary. But you have to remember that the link, the long-lasting links between the family doctor and his patient have a very good effect on all those recommendations. I can remember a study that I did when I started residency, and it was a very simple study. You know, in those days, no IRBs, no approval, nothing. We just decided, me and my mentor, that we will do a simple study. You know, you have the OCAD blood test kits, and we will randomly, not randomly, one yes, one no, we will give the patient the kit. For one patient, we'll say, just take the kit. And for the second patient, we'll say, okay, take the kit. This is very important. I really warmly recommend you to do this. This is an important procedure for prevention, etc. And we were able to prove that by this simple intervention by a family doctor, you doubled the compliance with this simple test. So I'm not saying that life is so easy and every time this intervention is effective, but it shows that it is not something that is easily delivered to other healthcare providers, and the family physician have additive value, and they should have protected time to deal with prevention and with proactive care of the elderly.
Before introducing, letting Professor Ungan to reply, we have a question. I have to read the question. What do you think will be the impact of artificial intelligence and machine learning on early detection, prevention, and vaccination in the next 10 years? The question is from Jose Miguel Bueno Ortiz. And this is a really interesting question. So it's also worrisome for us that people can think that they can get rid of primary care doctors. So, Professor Ungan.
Yeah, just very short. I'm not a native digital age, let's say, but on the other hand, I have been working with Ana Luisa Neves, who has a kind of very good project on it, and the effects of the digital health and also the AI may be working. The people are working, but also the GPs and the Imperial College is working on it, as I see. But my idea, my impression is, I think it is a useful tool to some certain extent. But at the end of the day, I think it's about as you see from my presentation, this is very important to initiate the general practitioners, the family doctors conversation and the interaction with the issue, whatever it is. It's prevention or whatever it is. If you combine it together, this is the most effective method, according to the meta-analysis until now. So I don't want to prolong this comment, but it's like, I have been always thinking something like, this is like a horse. It's running towards you, and either you will be hit by it, or you will be just jumping over it and just directing which direction you should go with. So I think this is the second one, which I would like to do, actually. And I think that it will be like this.
Personally, I think that the added value of the physical primary care doctor is important, also in the prevention, playing a real model. If you see your primary care doctor who doesn't smoke, who do physical exercise, avoid drinking too much alcohol, it's really important to convince the patients that this is the way forward. What do you think? Maybe on this question, maybe I would like also to have the comment by Professor Vinker and Professor Frese on the artificial intelligence, the role of artificial intelligence and machine learning.
So I will start. I don't know what will be in 10 years from now. I don't know. But I can tell you that in the coming years, what I'm seeing now is that the AI gives us the option to prioritize. We have shortage of time. Time is the most important resource that we have. So it's to prioritize. So for example, patients that with shorter longevity, life expectancy, they will not recommend to do, for example, early detection, that we need 10 years to show the benefit. And on the other side, the AI can now put a light on high-risk patients above the average. And then, for example, we have now a software that can give you, we call it KI, a detection of patients with higher risk for colorectal cancer according to certain algorithm of laboratory tests. So for the coming years, what we are seeing now is that AI will give us priorities. For 10 years, I don't know.
Okay, Professor Frese.
Yeah, I'm quite tense to see what will happen. And basically, I would not just say AI. Even if we would just start to implement algorithms, this would help on the more simple matters like vaccination schemes. But if we use artificial intelligence, it may really help us on the matter of early detection and prevention. It may help us to set priorities correctly, but we have to define it as Mehmet said, and we have to be part of the process when implementing it, because what we are currently asking in the project, Shlomo Vinker is also involved, is which data do we need so that AI can work. And there are many things which have to define to get the artificial intelligence run, because it will need information. And we have to find these informations from our patients.
Okay, I have now a few questions in the chat. One is for maybe for Professor Shlomo Vinker, but you already have answered if Israel had a program for screening, and you have already answered, but maybe you can answer to the whole audience.
I'm not sure that we are not
Israeli
dealing with we are not dealing with individual countries. I think so answered it privately.
Okay.
The main issue is about Europe, and we have more than 40 countries, and it's totally diverse. We are talking about the principles.
I have a very long questions, and I'll have to read it.
I read
Sorry,
it.
but...
I read it already, and I will ask Thomas and Mehmet because I had the time to read it. It's about the very old patient. The very old, do we need to manage them differently? So
yeah, I mean, this is a very basic point. It's also linked to another point, and it's linked to the response you gave prior. I mean, it's aiming about the representation of very elderly people in clinical trials, indicating about benefits on preventive early detection measures, which is not clear. It is shown for certain diseases that the patients included in the studies are not the patients we see in the general practice, and it strictly points to the fact that we need clinical trials to be run in primary care and general practice family medicine settings first, and it points to the second fact that we should think strictly about applying the time until benefit model. So Shlomo, you brought facts about prevention depending on the life expectancy, and this should much more emphasized. I think it's a core point when dealing with elderly patients in the general practice family medicine to think when you stop certain preventive or certain therapeutic measures, but we still have not very solid recommendations and rules of how to do this.
There is a question which is in a way related to the previous one, but it's more specific about the quaternary prevention, so the excess of prevention. And in Europe, in the last decades, there have been an increasing success of some movements based on this concept of quaternary prevention. What is your idea when we should consider that this is good, this is enough, or this is too much? A red line in early detection, prevention, and vaccination. It's good to have the answer from all of the three of you.
Yeah, I think this is very important to have the quaternary prevention issue. There are some discussions. You know, those authors who are writing about it, like Mark Jomu and Broderson and Carlos, they have been paying attention to some certain details, but I am not sure whether the other GPs across Europe are really paying attention to those details which are being discussed. So we have to be really knowing the definition. It's like action taken to protect individuals, persons, patients from medical interventions that are likely to cause more harm than good. And the goal is reduce over-medicalization, over-diagnosis and over-treatment, and iatrogenic harm. Those are I can understand it very well because I know the Nordic countries and Southern countries well, and the Central European countries. But I'm not sure whether it's very well understood and very well trained about the ordinary GPs like us who are practicing in daily work. So, I mean, this quaternary prevention is a good point to start for discussion about to what extent you have to be careful and to what extent you have to. But this is all about also the good clinical practices and also good guidelines, I think, which are protecting the patient and us in our daily practices. I don't know whether you will think something else, but I think if you read the last publications 2018 and after that about it, you can just have an idea about the discussions where it's going on. We should be thinking, we should be discussing still. And I think this is important according to the health systems and where you are living in. This is important.
I would say, Ferdinando, one comment. I would say that over-treatment or under-treatment are depending on the resources and the healthcare system. When you don't have enough time for the encounter with your patient, the chance that you will do over medicine is lower, and the chance that you will do under medicine in early detection, prevention, and vaccination is higher. So it really depends, and it really depends on the healthcare system, on the workload, etc. So it's not so easy. You can be aware for over the treatment and over medicine, but at the end you will do under medicine because of shortage of time and increased workload. So it should be the balance.
Okay. Thomas, would you like to add comments on this issue of quaternary prevention?
Just a very brief comment on what Shlomo said. I think, and I totally agree regarding preventive procedures, but regarding overtreatment, especially mistreatment, I'm not sure in undersupplied conditions. But I'm not sure whether there are any numbers and whether anyone has assessed, but I would think yes. And I feel that prescriptions leading to overtherapy could be more likely in a setting where GPs have short time.
Okay.
I think, Ferdinand, this is something that we should keep in our practice and in our minds, because this makes the primary care stronger than the other level of care, you know. But on the other hand, I think this is very correct what Shlomo says, that this is very important where you are and what are the resources you have. If you are living in Norway, Denmark, and other parts of the Europe, that will be really, how do you say, easier than the other parts of the, let's say, Eastern Europe, you know. So, I mean, this depends on where you are living also in. But we have to be we have to keep in our mind what is the best practice. So according to that, we have the capability as general practitioners and family doctors to judge where to stop and where to continue. I think this is important. And this is why we have this specialization, as I see.
Yes. Yes. So what do you think? Shlomo talked about the overtreatment. Overtreatment maybe in the very elderly people could be a real issue, polypharmacy. So in this case, maybe we could completely agree with this movement that we are doing too much when we have a very old patient with lots of condition. Giving them 20 drugs can be really risky and do not create a real benefit for the patient. But early detection, especially for those disease who can, let's say, cause death in a early age, I think that we have to be very careful to and facilitate the screening, facilitate the early detection of these diseases, and not just say that we are doing too much. What do you think? It's also apart the obvious consideration about the resources, but one thing, if you prevent cardiac death in a patient aged 40 or 50, another thing, if you want to prevent some diseases, just fighting risk factors in patients aged over 90. Today, I just visited a couple of patients aged 96, and I make this consideration in my mind during the visits. So what is your comment on this consideration? The overtreatment is a real problem, but not early detection.
I think that, you know, as Thomas said in the beginning, at the age, at the very, very old, we miss the data, we miss the evidence. I've been asking now in a forum of colleagues a few days ago, do I recommend to Shingrix vaccination for a patient that is 90 years old, 90? And I say, really, I can speculate that at this age, the immunization system works less, so it will be less effective. But on the other hand, maybe it will prevent a disease that will be much more serious in this age. So actually, we should look for more evidence at the very old age group, because this age group is going to be larger and larger. I don't know what will be with AI in the coming 10 years, but with elderly people, I'm sure that the numbers will increase significantly.
Okay, I have a question about, maybe we have a couple of minutes left, a question about this concept of vaccine fatigue, which seems to be to affect especially the COVID vaccination. Actually, even in my rural area, I've performed more or less the same amount of vaccination for the flu compared with the previous years, but the vaccination against COVID has, let's say, dropped. Do you have the same data in your own country, and what is the possible explanation of this?
Ferdinando, I'm not sure about concrete numbers, because I have the subjective experience from my practices, and I have the experience of colleagues which may tell me, and I just can say that the acceptance for COVID booster vaccinations did drop dramatically. It's just single doses administered in each practice. On the other hand, and I'm not sure whether this is really a vaccination fatigue or it should be named a vaccination fatigue. I think the appearance of COVID-19 changed. I've seen quite a lot of patients with confirmed COVID infection during the last month, especially this autumn, this winter. And each of us may just ask the question for our own and answer it. How many really serious ill people with COVID have you seen during the last months, during this year? So I would say, okay, on the one hand, the pathogenicity of COVID changed, and this is according to the textbooks that it's going more and more to be more and more contagious, but less and less pathogenic. This would be the normal way, unless there are accidents happening in the evolution, so to say. So from one point, I would say, okay, it's understandable that the demand for vaccination goes down. On the other hand, I indeed see that people do not want to hear something about COVID, and we are sorry to say, but in a way fed up with it. But this is not a very sophisticated explanation. Maybe Shlomo or Mehmet have a more sophisticated one.
Thank you. I will be short because we are running out of time. So I would say that I'm not worried about the vaccine fatigue from COVID, because COVID became a different disease right now. I'm afraid from the collateral effects, and I feel that people are more hesitating, and we saw it in one of the series of our webinar series, that people are now hesitating in general more with other vaccinations, even of vaccination of children. It's not the topic of our discussion today. So this is what frightened me, that people will stop to vaccinate, and we will see forgotten diseases. We have now, we had now measles. We have now an outbreak of measles in Israel, because in a kindergarten, children were not vaccinated, and and it was breakthrough even to the children that got the first vaccine, that usually protects you if the environment is with the herb vaccination. So I'm afraid about the collaterals, not about COVID, because if COVID will raise and we have effective vaccination, everybody will come back to vaccinate. The issue is with other vaccinations.
Okay. Okay, a final, maybe very short comment by Professor Ungan, very short, because we are running out of time.
Thank you. This is actually very nice topic, and we can discuss till the morning. I think very shortly, I can tell you, I agree with Shlomo. This is important. Even the United States started to ask for those who are immigrating to their country, one additional dose in the last 12 months, whatever the COVID vaccine, but approved by the WHO. It is the criteria. So if we think about it, the acceptance of the people who are accepting to have the COVID vaccination, then they are easily accepting the other vaccinations also. So this is a kind of practice that we learn, I think, about the perception of the people about the vaccination stories. But to be honest, this is a difficult story, and again, it's depending on the countries which are the people are coming to your country. And that Turkey is like a kind of passage, from east to west, west to east,
Okay.
So we have a lot of experiences we can share later. Thank you, Ferdinando.
Okay. Thank you to all our distinguished presenters, and thank you for the participants. We have to stop this webinar. Thank you very much, and good night.
Good night. Bye-bye.
Good night, all. Bye-bye.